Today's topic is colorectal carcinoma, part of gastrointestinal or carcinoma colon or adenocarcinoma. Introduction of आवाज आ रही है बेटा? Introduction of colorectal carcinoma. It is the most common malignancy of gastrointestinal tract. It is a major cause of morbidity and mortality worldwide. Most common primary tumor of the colon. Typically, it arises through the chromosomal instability pathway in 70 to 80% of cases, or microsatellite instability pathway in 10 to 15% of cases. The stage is the most staging of the cancer is most important prognostic factor. Epidemiology. The carcinoma colon represent nearly 10%, 10 point something percent of all the cancers in the body. 10% in male and as well as 10% in females. There's little bit difference. Peak incidence of this carcinoma occurs at the age of 60 to 70 years of life. It is the third most common cancer among men and women, and it is a second leading cause of cancer deaths. The 20% of cases occurs before the age of 50. The risk factors for colon carcinoma. Most important dietary factors involved are: number one, the low intake of unabsorbable vegetable fibers, low intake. High intake of refined carbohydrates and fats. The deficiency of multivitamins A, vitamin C, vitamin E. Few other factors involved are age above 40, 50 years, smoking is strong etiological factors for carcinomas, hereditary non-polyposis colorectal cancer, HNPCC or Lynch syndrome, inflammatory bowel disease, and pelvic radiation exposure previous. Pathogenesis. The pathogenesis of colorectal carcinoma is the combination of molecular events that leads to the adenocarcinoma are: number one, the genetic pathways as well as epigenetic pathways are also included. The genetic pathways are APC and beta-catenin pathway. Second is the microsatellite instability pathway. APC, beta-catenin pathway, it is associated with WNT and adenoma carcinoma sequence. There is loss of one normal copy of APC, a tumor suppressor gene. The individual born with one mutant allele or the inactivation of APC occurs in later life. APC, it is a key negative regulator of beta-catenin, a component of WNT signaling pathway. The APC protein normally binds to and promotes the degradation of beta-catenin, and the loss of APC function, there is accumulation as well as translocation into the nucleus of beta-catenin. Here it inactivates the transcription of genes which promote the proliferation of cells. Additional mutation here in this case are in KRAS, which promote the growth and prevent the apoptosis. SMAD2 and SMAD4, these are the effectors of transforming growth factor beta signaling, which inhibits the cell cycle. Mutation in the tumor suppressor genes encoding SMAD2 and SMAD4 also leads to tumor progression. P53 mutations. These are also seen in 70 to 80% of colonic carcinoma. Microsatellite instability pathway. Accumulation of mutations. Okay, beta. Accumulation of mutations in microsatellite repeat due to the deficiency of mismatch repair results from results from loss of mismatch repair genes causing microsatellite instability. As these microsatellites are in non-coding regions, so the mutations are generally silent, but as some microsatellites are located in promoter or coding regions of the genes, which are involved in the regulation of cell growth. So mutations in the BRAF oncogenes and CPG island hypermethylation are causing this silencing of genes. Both when combined with microsatellite instability, they progress to the carcinogenesis for colonic carcinoma. This one is the pathogenesis. Now, morphology. Morphology and pathogenesis in case of colonic carcinoma is very important, so please be attentive. Morphology is somewhat different in the left as well as in the right. There is slight difference in the morphology. The distribution of carcinoma colon is equal over the entire length of carcinoma. No change in the distribution, but usually it is single and polypoid or ulcerated mass and may cause serosal puckering if muscularis propria is involved. The tumor in the right side of the colon tend to be polypoid and exophytic. Exophytic means cauliflower-like. While in the left side of colon, tumors tend to be annular and circling lesions producing napkin ring constriction, which results in the luminal narrowing. As you know that on the right side, lumen of the colon is wide. Gross image of this exophytic lesion. This one is the exophytic lesion. You can see the folds of large colon, large intestine. This is the polypoid mass, polypoid tumor arising in the cecum. It has well-defined rolled out margins which are sharply demarcated from the surrounding normal mucosa. The exophytic lesions are more common in the proximal colon and they appear as a bulky polypoid mass with rolled edges that are clearly demarcated from the adjacent mucosa. This one is this whitish mass this encircling the lumen. This one is the circumferential growth in the descending colon, 45 centimeter proximal to the anal verge. This specimen shows a 5 centimeter fleshy gelatinous tumor causing the narrowing or stenosis of the lumen. In distal colon, exophytic lesions tend to be annular and can cause napkin ring constriction of the lumen. Usually well or moderately differentiated gland lined by tall columnar glands. This is a microscopic picture. Well differentiated or moderately differentiated glands which are lined by tall columnar or glandular epithelium. The carcinoma with marked stromal desmoplasia, particularly at the age of tumor. Glands often filled with necrotic debris in the center, which is called as dirty necrosis in both the primary site as well as metastatic sites. The inflammatory cells and scattered neuroendocrine cells are commonly seen. Tumor may be composed of signet ring cells. Sometimes tumor may display the features of neuroendocrine differentiation. This one is the microscopic picture of the well differentiated adenocarcinoma. You can see a lot of tubular glands, and you also notice these glands are connected. Connected. Okay, beta. This one is a well to moderately differentiated adenocarcinoma, which is consisting of tubular anastomosing and branching glands in a desmoplastic stroma. Stroma is desmoplastic. Glands are more than when compared with the stroma, more in number or more in quantity. These glands are tubular form and glands are connected as well. So tubular anastomosis is seen. Glands are tubular and anastomosis is seen between the glands. And the cell type, notice here, please notice here that cell type is tall columnar. Again, this is a morphological features, microscopic picture of the adenocarcinoma. You can notice the glandular appearance. Glands are here, tall columnar epithelium, but this is moderately differentiated. See the glands. Inside the glands, there is mucin secreted, a variable amount of mucin, and these glands are composed predominantly of columnar cells and goblet cells. An inflammatory infiltrate of lymphocytes, mostly T cells, are here. Plasma cells, histiocytes, and dendritic cells are commonly present in the stroma. This one stroma is filled with inflammatory cells, plasma cells, and dendritic cells. This one is again the microscopic picture of signet ring cell carcinoma. Signet ring cells. You can notice here in between these cells, signet ring cells. The image shows signet ring cell carcinoma of the colon that has penetrated through the muscularis propria and involved the subserosal adipose tissue. बेटा मैंने आपको पहले ही कहा था कि स्टेजिंग और ग्रेडिंग जो ट्यूमर की है इट इज वेरी इंपॉर्टेंट. In well differentiated adenocarcinoma, 15 to 20% of the all carcinomas are well differentiated. There is well formed glands or simple tubules with uniform basally oriented nuclei. Nuclei आप देखें तो basally oriented nuclei, well differentiated. ये features हैं बेटा. Somewhat resemblance with adenomatous epithelium in well differentiated carcinoma. In moderately differentiated carcinoma, these are 60 to 70% of the all carcinoma. Tubules may be simple, complex, or slightly irregular. Nuclear polarity is lost here. Third type is poorly differentiated carcinoma. This one is the 15 to 20% of all the carcinomas, and there is less than 50% of the gland formation. बेटा मैंने आपको पहले दिखाया था कि the glands are more here. The percentage when compared with the stroma glands are more than the stroma. So this one is the well differentiated, but in the poorly differentiated, one of the characteristic is that less than 50% is the gland formation, and the majority of the tumor, excluding their ages, they consist of sheets of cells without gland formation. So that's why it is termed as poorly differentiated. Clinical features or clinical presentation in the case of adenocarcinoma colon is very important. Here there is abdominal pain, vomiting, and constipation. In the right-sided tumors, there is anemia, weakness, and fatigue. Patient present with anemia, weakness, and fatigue, unexplained anemia. While on the tumor on the left side, it causes changes in the bowel habits, either diarrhea or constipation, or alternatively both diarrhea and constipation. Colorectal carcinoma is clinically silent in the earlier stages, and tumors in the proximal colon, in the cecum and the right colon, they rarely cause obstruction due to the large caliber of bowel in these mutations. Instead, they often present with fatigue and weakness due to the iron deficiency anemia from chronic blood loss. Clinical features continue. The left side colon cancers can produce occult bleeding, altered bowel habits, and the left lower quadrant pain or cramping and intestinal obstruction. Staging of the cancer presents by American Joint Committee on Cancer (AJCC) as well as the new cancer staging or classification for colorectal carcinoma is also used. So here I am only presenting the tumor part of the staging, while the T and M, T for tumor and for nodal involvement, and M for metastasis. The TNM staging system is the most widely used system in North America. Tumor is classified based on the depth of invasion. Here, the TX is the primary tumor which cannot be assessed, is labeled as TX. T0, there is no evidence of primary tumor. TIS, it includes the high-grade dysplasia and intramucosal carcinoma. Tumor is confined to the mucosa, and the cancer cells invade into the lamina propria, may involve but not penetrate through the muscularis mucosa. Here, at this stage, the risk of metastasis is negligible. T1 stage is the tumor has invaded through the muscularis mucosa into the submucosa. Muscularis propria is spared. T2 is the tumor penetrate through the mucosa into but not beyond the muscularis propria. T3 stage, the tumor penetrates through muscularis propria to involve subserosal adipose tissue or perirectal soft tissue. In the T4 stage, the tumor involves the serosal surface or visceral peritoneum or directly invades adjacent organs or structures. It is divided into T4A and T4B. T4A is the tumor invades through the visceral peritoneum, including gross perforation or bound through tumor and continuous invasion of the tumor through areas of inflammation to the surface of visceral peritoneum. T4B is tumor directly invade or adhere the adjacent organs or structures. At the T4 stage, tumors have a higher risk of peritoneal relapse The significance of tumors that are less than 1 millimeter from the serosal surface and accompanied by serosal reaction is unclear. Multiple sections should be examined for definitively rule out the serosal involvement. The nodal involvement and metastasis part of the TNM classification followed you can follow in the, from the book. The diagnosis of tumor is generally it is discovered on the colonoscopy. Barium enema is used. Serum carcinoembryonic antigen is also used, but it is not a definite marker. Biopsy and histopathology finally is used for the definite diagnosis of the tumor. Now the tumors of anal canal. Anal canal is divided into three zones. Histologically, upper zone is lined by columnar rectal epithelium. Middle third is lined by transitional epithelium, and lower third is lined by stratified squamous epithelium. So the carcinomas arises in the anal canal are glandular or adenocarcinoma, squamous cell carcinoma, and basaloid carcinoma. Basaloid carcinoma actually these are the immature cells derived from the basal layer of transitional epithelium in the middle part. When entire tumor displays the basaloid pattern, it is termed as glycogenic carcinoma. The squamous cell carcinoma arises here are associated with the human papilloma virus, which is the and the precursor lesion for the carcinoma. Squamous cell carcinoma is condyloma acuminatum. Hemorrhoids. Hemorrhoids develop secondary to the persistently elevated venous pressure within the hemorrhoidal plexus. The most common causes are constipation or the venous stasis of pregnancy. Pathogenesis. The visceral dilatation of the anal as well as perianal venous plexus form the collaterals that connect the portal and cable venous system, thereby relieving the venous hypertension. The morphology of hemorrhoids. Hemorrhoids are divided into external as well as internal hemorrhoid according to their location. The external hemorrhoids, these are collateral vessels within the inferior hemorrhoidal plexus located below the calorectal line. Internal hemorrhoids, these are result from the dilatation of superior hemorrhoidal plexus within the distal rectum. These are thin-walled, dilated submucosal vessels that protrude beneath the anal or rectal mucosa. They can be inflamed, thrombosed, recanalized, or superficial ulceration may occur. Clinical features are pain, rectal bleeding, fresh red blood on toilet tissue or after defecation noticed. Thank you, Beta. Any question, Beta?